Welcome everybody. I'm thrilled to have to welcome you here today. So to our HCV Action webinar, 3 years to go. Where are we in the journey to hepatitis C elimination? So what we know is, not what we know. So recently there was a report published by UKHSA, which was the data up to and including 2020. In this report, it was deaths had fallen by 35% between 2015 and 2020, and the prevalence was down to 37%. Fantastic. However, what we also know is that COVID-19 has impacted treatment and testing, with the falls in testing, diagnosis and treatment initiations. So today's webinar, I can't believe that we've actually only got 3 years left to go, but today's webinar, seeks to update all of us working in the hepatitis C arena, what is the latest data available, how's it collected and estimated, what the data tells us both about our progress towards elimination by 2025, and where we should be focusing testing and treatment efforts to reach elimination, and finally to discuss, what further data is needed to guide these efforts, because actually, with this goal to elimination, we're not going to reach it if we don't have the data to evidence it. So today we have a wide range of speakers. We have speakers sharing their perspective from UKHSA and NHS England. And also we've got those from the services that we know are key to addressing hepatitis C, including prisons, drug services and community work. So rather than go on any further with an introduction, let's just get into the sessions. Just wanted to say a little bit of housekeeping. Please, if you have any questions, put them into the chat box. We've got somebody monitoring them. And then we have allowed at the end of the sessions, a good 20-25 minutes for Q&A. And just to finally say that we are recording this and the webinar will be published afterwards. So swiftly done in 5 minutes there. So I'm the timekeeper here and I really want to keep this to time. So it gives me great pleasure to introduce you to our first speaker, Monica Desai. Monica is the head of hepatitis C and bloodborne virus infections for UKHSA. And she's going to be talking to us today, progress towards hepatitis C elimination, date to end of December 2020. So over to you, Monica.
Brilliant. Thank you, Rachel. And thanks so much for the invitation to speak today. So as Rachel said, I'm going to talk through very briefly some of the data that's in the Hepatitis C in England report. And you can find that on our website with much more detail about the data and the methodology that underpins it. But I will try and give you an overview today. Just before I start, huge thanks to the team who've produced these data, particularly Helen Harris, who has now left UKHSA, and Anastella Costello. Next slide, please. So just very quickly to recap, in 2016, as we know, the UK signed up to the WHO's ambition to eliminate hepatitis C by 2030, the NHS declaring an ambition to eliminate 5 years earlier. The initial targets were relative compared to 2015 baseline, and in June of last year, the WHO published a set of interim absolute targets. And briefly, the two main impact targets were around hepatitis C incidence and hepatitis C mortality. Next slide, please. And then there were programmatic targets, previous slide, thank you. Programmatic targets about diagnosis and linkage to treatment. Next slide, please. So the data that we have here is an overview of the progress that we've made in England to the end of 2020 against the WHO metrics. And as I said, there's more detail in the Hep C in England report. So in England, at the moment, we use change in chronic prevalence as a proxy measure for change in incidence. And we know from extensive modelling work that incidence is roughly proportional to changes in chronic prevalence. And it's one of the methods that's advocated by WHO. So in 2020, the estimated prevalence of chronic hepatitis C infection in the general population continued to decline to 81,000 amongst all persons. So that's a 37% decline since 2015 baseline. Now, of that 81,000 living with chronic hepatitis C, modelling suggests that approximately a third of those infections are in people with current or recent drug injecting risk. 62% are in those with a past drug injecting history, but who are no longer injecting, and 11% are in those with no history of injecting. So that split is really a reflection of the great work that's being done in drug services to test and treat those at risk. And there remains a significant burden of chronic infection in those who are not in contact with drug services. So we have been working very closely with NHS England to support the pilot work in emergency departments, antenatal care and primary care, which Graham might comment on further in his talk. But just to note that essential to the effective rollout of these interventions is evaluation to ensure optimal implementation. Next slide, please. So this graph here shows you how estimated prevalence of chronic hepatitis C infection in England has continued to decline since 2010, most markedly amongst current injectors who are in dark blue. So you've got time along the x-axis, numbers of chronic infections along the y-axis, and dark blue are current injectors, light blue past injecting history, and then your very light blue is those that have never injected. And you can see the decline from 2010 to 2020. Next slide, please. So if we do look specifically at chronic prevalence amongst people who inject drugs, we derive a lot of this data from the UAM survey that suggests that prevalence of chronic hepatitis C infection in people who inject drugs has declined to 17.3% in 2020, which is brilliant. So in that dark blue section, you can see chronic hepatitis C infections, so those that are antibody positive and RNA positive. Just worth bearing in mind, though, that the 2020 data still remains provisional because of sampling restrictions during COVID-19 and change in risk profile. So going forwards, we will be combining 2020 and 21 data to give us a clearer picture, but that is a significant decline. However, what we have seen is that there's been an increase an increase of those that have ever been infected with hepatitis C. And if you combine that with recent decreases in chronic hepatitis C prevalence, so active infection between 2015 and 2020, it does suggest that what we're seeing is an effect of access to treatment rather than improved harm reduction as the main driver of the reduction in prevalence of chronic hep C amongst people who inject drugs. Next slide, please. So this slide here is just to give you an idea of one of the reasons why we're currently using change in chronic prevalence as a proxy marker for incidence. So as I said, WHO's absolute impact target is based on hep C incidence, but incidence is very difficult to measure directly. And Graham will comment on that, I think, in his talk. But there are a number of direct methods that can be used that are feasible mainly in higher risk populations. And we've got indirect methods there as well that include estimating hepatitis C incidence based on hepatitis C prevalence and risk behaviours. And that's primarily what we use at the moment in the UK. And then finally, we've got in England, sorry. And then finally, we've got surveillance-based methods that infer incidence trends that can also be used. So at the moment, we're using indirect methods. Next slide, please. So in England, using the indirect methods, we use an epidemic model, and that uses multiple data sources. So it's not just one data source. We use a series of data sources that take into account the long-term trends in injecting drug use, infection rates in people who inject drugs over time, so trends in time, disease progression, and hepatitis C related outcomes from HES data. So that's directly from hospital episode outcome data. And that's all fed into a model that estimates the number of new chronic infections and how that changes over time. Now, as that model is iterative, so as there are more data available, those will all be considered to be incorporated into the model to provide further refinement to the estimates of chronic infections over time. Next slide, please. Okay, the other thing I just wanted to comment on is the potential impact of reinfection. So we have at UKHSA piloted, and this is very much the pilot experimental data, to estimate the impact of reinfections following treatment. And what we do know is that as the numbers of infections decline, we need to bear in mind the impact of reinfection rates, those who have continued risk or at risk of reinfection. The preliminary estimates that we have suggest a conservative reinfection rate of 8%, so sorry, if you can just click again, sorry, of 9% with median follow-up. Can you go? Thank you. With a median follow-up time of 1.3 years, but that reinfection rate is higher amongst those with a known history of injecting drug use, about 11%. The methodology that we've used has used three different criteria for classification, all starting from a treatment start date, followed by either documented SVR or RNA negative result at an appropriate time interval, and then a positive RNA or subsequent treatment date, or if we don't have a subsequent RNA test, a subsequent treatment start date after the initial treatment. Now, as I mentioned, this is experimental and really value feedback on the methods that we've used. Next slide, please. Okay, so moving on now to mortality. As Rachel mentioned, since 2015, Hep C-related mortality fell by 35% by 2020, and that's surpassed more than threefold the WHO 2020 elimination target of a 10% reduction. The interim absolute target of less than 2 per 100,000 has already been hit in England, where we sit at 0.56 per 100,000 population. We've also seen significant declines in first hospitalizations for Hep C related liver disease and also first liver transplant. Next slide, please. So this is just a graphical way of showing you, if you look at the orange line, two orange lines, which are the 2020 and 2030 WHO targets, you can see that we have surpassed those in terms of death registrations and mortality rate. Next slide, please. Now, one of the programmatic targets is awareness of hepatitis C infection, and in 2020, 40% of injecting drug users sampled in the UAM survey were aware of their current chronic infection, so really quite low. But that is a reduction from that seen in 2017 when data were first available. That is currently our mainstay of data, and we are aware that the question around awareness of Hep C infection does need to be modified. So in the 2021 round, we 2022 data, sorry, we're taking into account tests that are happening on the day. So that estimate will be further refined. Next slide, please. Okay, so a further programmatic target is prevention of hepatitis C infection. And as I mentioned earlier, the impact, the decline that we're seeing in chronic Hep C prevalence is more likely due to the impact of treatment rather than prevention. And what we do know from the UAM survey is that around 2 of every 3 people injecting psychoactive drugs report adequate NSP provision for their needs, which falls below the WHO target, and much further work needs to be done to prevent both primary infection and reinfection following hepatitis C treatment if we're going to achieve and sustain elimination. Next slide, please. So whilst we've made lots of progress in increasing the numbers accessing hepatitis C testing, particularly through the stellar work of the NHS England funded elimination initiatives, we do know that testing has been impacted by the COVID-19 pandemic, only partly recovered. And so if we're going to meet elimination targets, we really do need to redouble the efforts to ensure that everybody at risk of hepatitis C infection, including those who've been treated with, who remain at ongoing risk, can access testing. And we need to really consider and redouble our efforts to make sure we reach underserved groups, particularly as numbers with hepatitis C infection fall. And we need to make sure that we're implementing and evaluating approaches that facilitate testing and treatment of these groups at greatest risk. Next slide, please. So the final programmatic target was around treatment uptake, and there's been a huge increase in the numbers accessing hepatitis C treatment thanks to the elimination programme and the work done in the ODNs and through the stakeholders on this webinar, so that around 58,000, almost 59,000 treatments took place between 2015 and 2021. But we need to do a lot more work to reach the 2030 WHO target of at least 80% of people with chronic hepatitis C accessing treatment. Between 2015 and 2020, that figure was 65%, although amongst those who were treated and not lost to follow-up, we have very high cure rates of 95%. Next slide, please. So this is our sort of first go in this year in the 2020 report of the care cascade for people for individuals testing hepatitis C RNA positive. And what you can see here is that, so this is data from 2015 to 2020. So if you look at group of individuals testing RNA positive, we then follow through the dark blue part of that column because we had a significant proportion who didn't have a recorded NHS number or name and date of birth, so we weren't able to link those individuals. 73.5% of the dark blue first bar were linked with the treatment database, and we know there are issues with the treatment database and being able to link identifiers across. And then the care cascade follows through. So 89% started treatment after being PCR positive. Almost 90% had a reported outcome. And of those, 78.6% had a recorded SVR, which gives us the overall 65% figure to report against the WHO metric. Next slide, please. It's my last slide, Rachel. So just to conclude that elimination of hepatitis C is achievable, but we need to make sure that we redouble efforts, that we really target all points in the care pathway, and we need to make sure that we address inequalities, particularly following the COVID-19 pandemic. We need to redouble efforts to improve harm reduction, testing and access to treatment for the most vulnerable populations, or inequalities will continue to widen. Thank you very much.
Thank you, Monica. So much information in there, and already there's lots of questions coming in. Please, if you've got questions, put them in the chat box so that we can pick them up at the end. So you're going to stay around, aren't you, Monica, for some questions? Yeah, perfect. I'm going to move on to NHS England, and we have their perspective on current data, and we have Graham Foster, who's here, who doesn't really need any introduction. Graham is the National Clinical Lead for ODNs and NHS England and NHS Improvement. Graham, over to you.
Rachel, thank you very much indeed. Thanks for the invitation, and thanks to Monica for setting the scene. I'm going to give a slightly different slant on the data. The discrepancies between what NHS England are looking at and what UK HSA are looking at are really very important. We need to understand them, and we need to work collectively to try and narrow the differences and try and work out exactly where we are in the elimination cascade. So let's have the first slide, please, and a summary of where we are. From the NHS England perspective, we've seen hepatitis C elimination as 3 phases. The first is getting onto people with advanced disease, and that started with the early access programme for decompensated cirrhosis. We then moved very quickly to treating people who were at high risk of transmitting to others, predominantly drug services. And the final phase, and probably the most difficult, is getting to people who were infected in the past and don't know they're infected. Next, please. The first phase has been a great success, and Monica's data, I think, shows very clearly that deaths and transplants are plummeting, and that's entirely due to pressure at the beginning of the programme on people with advanced disease. Next one, please. But I do just want to flag that things are going to get worse from now on. And the reason things are going to get worse is this little uptick in liver cancers that you can see on this UK HSA data set. The reason for that, of course, is you can only die once. And if you have decompensated cirrhosis from hepatitis C, and we cure your hepatitis C, you then won't die of decompensated disease. You're then living long enough to be at risk of liver cancer, I'm afraid. So it is likely that we will see an uptick in liver cancer purely as an impact of our treating people with cirrhosis who are not going to die from decompensated disease. And we need to factor that in and be ready for an increase in hepatitis C deaths. But if we look at the age of those people, they should be dying at a much older age than people were dying in the past. So we're buying extra years of life, but in people with cirrhosis, we're probably buying extra years, not curing. And that, of course, makes it all the more important to treat people before they're cirrhotic, when they don't have a chance of getting cancer if we get rid of the virus. Next, please. The next phase was to move into addiction services. This, for me, has been the triumph of the hepatitis C programme. If you look at the BSG guidelines on hep C treatment of a few years ago, they said people who are actively using drugs should not be treated. We have completely turned that round. We now have treatment programs in just about every drug service in the country. They're not perfect, but they're an enormous amount better than they were 10 years ago. And we've now taken people who are actively injecting drugs and allowed them to access healthcare services. And that has been a transformation. And part of that has been driven by the peer program and the Hepatitis C Trust. And we know that they've had a huge impact. But it really is heartwarming to see that we no longer regard people who are homeless, people who are using drugs, as unfit for treatment. We actively engage them, and long may that continue. Next, please. We know the numbers are falling in addiction services, and Monica made that point very clearly, but next slide, please. But what we do have is concerns about reinfection, and we do have concerns about the hidden populations. And I think that both Monica and I are concerned about the reinfection numbers and concerned about the hidden populations. We do know that we're making good progress in prisons. George is going to give you better data later on. But if I tell you that 20% of antibody positive people are RNA positive, that is a massive impact, and long may that continue. Next, please. If we look at people attending emergency departments, this is data from East London. You can see the proportion of people who are antibody positive has stayed pretty constant over the years. That's what you'd expect. But the number with RNA positivity, viremia, has fallen, and that is continuing to fall. So a very good indication that we're making huge progress. Next one, please. And the final bit of data, again, good to see that the homeless, the disadvantaged are very much in our thoughts. This is data from the London Joint Working Group, showing that in London, the proportion of homeless people who are viremic is very small, in fact, substantially smaller than in the rest of the country. So we think we're making real progress in getting these disadvantaged groups into therapy. Next slide, please. One of the big contentious issues is whether we've done enough to stop transmission, and that is a really difficult question to answer. We are worried about reinfection. The data in the UK HSA report says that there hasn't been a change in transmission, but prevalence has dropped. Not sure that makes sense. I think if the prevalence goes down, we would expect the incidence to go down. So our view is that incidence has fallen, but it's proving very difficult to measure. Next one, please. I think the reason that the UK HSA report says that incidence has not changed is that the error bars are too wide, and that's because the data set is too small. And if we're looking at very small numbers of transmission, we need to do an awfully big study to show that transmission is stopping. And that's expensive and difficult, but we're going to have a go. Next one, please. So what we're going to do is to push to test 10,000 people in addiction services. We're going to do an antibody and an RNA test on the first sample to pick up acute infections. And we're then going to go back a year later and retest to see how many are getting new infections. And that will bridge the gap between the different data sets and tell us whether or not we really have stopped incident infection. We were hoping to start this in May, June of this year. A lot of you have come back to us saying that that's not a realistic goal. There's too much else going on. So we're probably going to push this back until September time. But this really is important to us because this will tell us exactly where we are within the addiction services and tell us where to focus. Next one, please. And that takes us to where I think is the biggest unknown, which is how many people are left in primary care. How many ex-injecting drug users are not aware of their diagnosis, are not getting treatment? The models from UK HSA says there's an awful lot of them left, probably 60, 70,000. That's a big number to find. I'm not convinced that's right, though. Next one, please. The data from UK HSA is based on a model, of course. And as Monica says, a lot of data goes into that model. But one of the key features in the model is the number of people who are dying and developing cirrhosis. In a very simple way, if you say 10% of people with Hep C will die from it, and you have 10 people dead a year, that means there's 100 people with Hep C left. But of course, if you're wrong, and if 20% of people with hepatitis C die, and you see 10 deaths a year, that means there's only 50 people left. So this data is very dependent on our understanding of the natural history of hepatitis C. And we don't really have good data on what happens to people with hepatitis C over 40, 50 years, particularly if they're drinking, particularly if they have other comorbidities. So what I'm showing you here is data from the UK HSA model that Ross Harris very kindly gave me, and the data on the number of people with cirrhosis on the UK treatment registry. And you can see there's a very big difference. And if the UK registry is typical, and of course people getting treated may be more likely to have bad disease, so this may be an overestimate of the proportion with cirrhosis, but it might indicate that the UK HSA estimates are perhaps higher than they should be. Next one, please. We also have a real problem with past injectors. One of the things we know about past injectors is that they have other lifestyle issues, particularly alcohol and other addictive disorders, and they may die younger. Homeless people, for example, have an average life expectancy of 43 years. So a lot of the people who use drugs 60, 70 might already have died. And we know that some of those people who use drugs in the 60s and 70s have found creative ways to access treatment. I spoke to one of the people who runs a buyers club. They've treated over 1,200 people from England. That's just one buyers club. And they're people who used drugs a while ago and don't want a history of drug use on their NHS records. So we don't know how many of these ex-injectors are still actively infected. Next slide, please. This is really tricky for us because to find people hiding in primary care is a huge effort, and there may not be very many left to find. And of those left to find, not all of them will agree to be tested or treated. So let's say 50% of people agree to be tested and treated. If there's 60,000 people left, we've got 30,000 to find. If there's only 30,000 left, then that might be 10 to 15,000 people left to treat. And that would require a lot of investment. And is that the right place to put the NHS money? So this is a really important question for us. How much effort do we put in to finding people in primary care? Next slide, please. So again, the solution to that is to get some data. Once we know who to go for, we can test them in different ways. We can contact patients directly. We can get GPs to flag them. We can give them a telephone call. We can give them a text, or we can go bang on their door. And of course, how much effort we put in depends on how many people we think are left. Next one, please. So what we're doing is looking at where we need to invest our resource. We're asking the networks to go into primary care, find people with risk factors and go and get them tested. Let's see who's out there. With Matt Hickman and the UK HSA team, we're doing 100,000 people. We're going to contact them, send them swabs, get a Hep C test. So 100,000 random people, find out who's got Hep C. We're testing up in Liverpool 18,000 samples, people who've turned up to hospital for a blood test, and we're testing surplus samples for hepatitis C. So we're going to look at 140,000 people. And that will really give us some high quality, accurate data. And then we can get a strategy to eliminate in primary care. Next one, please. The final string in our armament is to have a testing website. There are people who really don't want to engage with their GPs or primary care. So we're going to have a testing website. George has been leading on this, and we hope it'll be live in the next few months. You click on a link, it takes you to a request to test. You get a test, we tell you you're positive, and we send someone around to treat you. So we're hopefully going to get some of those reluctant to engage people engaging in services. The final one, please. We need to decide how much is left to do and how much we need to spend and what level of confidence we need to have. And I think it's important to remember, whilst we're all committed to clearing hepatitis C, there are other things that rot your liver. I sat in my clinic on Wednesday. I had a patient with hepatitis C who didn't show up, but that's fine. We'll give him another appointment for next week. We'll send the nurses around, we'll send the peers around, we'll get him treated. The 56-year-old with alcohol-induced liver cirrhosis is being put on a waiting list for access to addiction services. She might get in by January of next year if we're really lucky. Should we really be putting vast amounts of money into finding the last few people with hepatitis C and taking that away from other addictive services. So for me, I think we need to start asking the difficult questions is how can we get the level of other services up to the high level of hepatitis C, and where are we going to get best value for money? And I don't think it's an either or. I think what we should be doing is using some of the Hep C resource to treat other addictive disorders, to do more community work on a general health level, not just a let's get a hepatitis C PCR negative situation for as many people as we can. The final slide, please. So I think we are closing in on elimination. I personally think we're a little further down the line, but I quite accept when we've done our studies in primary care, I may be eating humble pie. There may be more than we think. We may have to accept that we've got it wrong and there's more people out there to find, in which case we'll go out and find them. But we are getting the data to do that. So I think we will get more confidence. And I think UKHSA and NHS England will reach a consensus view when the data comes in. And that will give us the confidence to invest, treat who we need to treat, and then move on. So the bottom line is, Rachel, I think we can do this, and we jolly well going to. Thank you very much.
Thank you very much, Graham. And I love that. I love your enthusiasm as ever. We can, we will, so much in there. The data, the additional pieces of work that we have to do to ascertain the numbers in addiction services, but also primary care. There are more questions coming in, which will come up at the end. I'm going to hand over now to Georgia, who's going to talk about prisons and data. So Georgia Threadgold is the Senior Project Manager for the Hepatitis C Elimination Programme, NHS England and NHS Health Improvement. It's not even, yeah, improvement, sorry. I think Sean from the Hepatitis C Trust might be talking with you as well, Georgia, but I'll leave that for you to introduce.
Thank you, Rachel. Yeah, Sean is here as well. So it's a double act this morning. So today we're going to be talking about some prison data and what we've done so far across the prison estate and what we have planned in the coming months, which will continue to push us ever closer to our elimination target. So I'll start us off this morning. So next slide, please. Thank you. So for those who might be less familiar with our extensive prison programme, I just want to spend a couple of minutes introducing the test and treat programme in prison and explain how it came to be, its importance to the wider elimination strategy and what our priorities are. So there are over 100 adult prisons in England. It seems to change all the time, so I just say it's over 100. And there are a few more currently in development. Several of our pharmaceutical elimination initiatives target the prison population as well. And since 2019-20, NHS England elimination initiatives have also supported elimination. And these include things like the high intensity test and treat, or HITs as we're going to refer them to, capillary blood programmes and the prison peer programme, to note a few. So we also have a large programme of work helping to increase reception testing, which I'm going to mention a lot in this presentation, which is testing people on arrival into prison or within 2 weeks. So prevalence across the prison estate, oh, you can go back one, yeah, that's fine, thank you. Prevalence across the prison estate so far sits at around 2.4% and is significantly higher amongst female prisons. This is an extremely important figure and highlights why this programme of work is so important, as the numbers represent many individuals who have found out that they've got a potentially cancer-causing virus that may not have done so during their time in prison without these initiatives. So although HITs and reception testing are incredibly important to the prison programme, what is also really central is that when testing or commencement of treatment is declined by a prisoner, which happens quite a lot, one-to-one support from the Hepatitis C Trust prison peers can make all the difference in enabling individuals to come to understand the significance of why we're offering them test and treat. And sometimes that offer is recurrent, you know, you get declined several times, but the peers are able to go in and provide that one-to-one support and explain why it's so significant. So the peers have massively increased the number of people that we've been able to test and treat across the estate. And I'm sure Sean will give us a little bit more information on that later on. So in terms of treatment, it's crucial that every single prisoner is commenced onto treatment before release, regardless of the time that they have left on their sentence. So prison healthcare teams have been really effective in ensuring that our prisoners physically have their treatment to hand before release and can be supported by probation services or others like drug and alcohol upon release. And the Hep C Trust peers are also able to assist with this kind of prison to community element as well. So our priorities across the prison estate so far have been twofold. The first is reception testing, and that's currently offered on an opt-out basis. Reception testing is important to the programme as it ensures the revolving front door of the prisons is closed, through encouraging all new prisoners and any transfers to be tested on their arrival into prison or within a suitable time frame. So although the offer rate is really high and the uptake is significantly higher than it was a few years ago, there's still quite a bit of work to do to increase this figure. So for those prisons who do get their reception testing up to a very consistent, stable and incredibly impressive at 95% or higher, it goes some way in contributing then to gaining the microelimination certification. Our other priority is the HITS, so the high intensity test and treat sessions, which ensures that we have tested the entire static population who may not have had a test on reception, or there may be a lot of time passed since their initial reception, and we recommend a retest. There are also people who have not been flagged as positive on reception when they did have their initial reception screen, as they've only very recently become exposed to the virus. So for both reception testing and HITS, we have primarily concentrated on the women's estate due to its higher prevalence, and also in those busy local and remand prisons that have a significantly higher turnover of prisoners. So next slide, please, and I will hand over to Sean for the next couple of slides.
Yeah, thank you, Georgie, for that. Yeah, we'll talk about the high intensity test and treat. It is what it says on the tin, a bit like one silver, really. That's what we're aiming to do. We're going to try and get in there, test as many people as we possibly can over a shorter period as we possibly can, and then get those people that are positive onto treatment in the shortest pathway as possible, for the reasons that George has just pretty much outlined. And also with that, it does also then contribute to the fact that we're looking towards the elimination and the microelimination within prisons. But just give you a bit of update what we've achieved so far this year, and I think it's only fair to say a big thank you to all the key stakeholders that are involved in this. George has very kindly, commented on the involvement that the peers have within this strategy, but it's about collaboration with all key stakeholders. And we've been in the pandemic. I think I've only heard that word a couple of times so far during these presentations, but the figures we're presenting are on a reduced service because we've not been able to access the prisons as much as we would do normally because they've been under gold command. But to achieve these figures in itself in that period is a credit to everyone's commitment to this strategy. So we have carried out 19 hits already within this last financial year. Within that, we've been able to test 92% of the population. So we've had very few decliners. Those that have declined are either because they were just recently tested and we've cross-referenced that data, and they just recently tested on reception, or they just really either were unable to access the service due to them being in court every time, or they may not have the mental capacity to be able to consent at that time. Out of those that have undertaken, one for national prison, which yielded, I think, one new case. As George said, we prioritised the female estates. We know the high prevalence in that, and the local reception prisons we've prioritised. And there has been the highest rate of antibody positives at 12.7% in one of those prisons, and we do see the increase of the PCR positive rates as well. There were 13,567 people tested out of a possibility of 14,585. And as you can see there, it's only the 676 decline, which gave us that 90% positive rate. It's found a total of 133 new RNAs, so they all started treatment. Within that, we did find one new reinfection rate. So the HIT strategy also does help us to hopefully pick up those reinfections as well that we've spoken about already. And just quickly talking on the hits as we move forward, we are looking at other initiatives in the prison. I just noticed someone put a chat there, so it's pertinent I pick it up there. We are looking at the IRCs as we move forward. There's meetings going on next week about IRCs, so yeah, we have not forgotten about the IRCs at all, and we'll be moving to those in the next few months as part of the strategy as we move forward. And next slide, please. So the benefits of the prison peer program, obviously I could speak all day, but I know Rachel's obviously going to be timekeeping us soon, and we're probably overrun already, so I will just give the headlines here. But obviously the key bits for us is we know increased engagement. People have already alluded to that, Georgia and Graham already, that actually does reduce that non-engagement. We do increase the uptake of reception-based testing. We're normalising the conversation around the prison estate now. We're not seeing as much stigma as perhaps we did 2 years ago. The peers also produce that instant identification of a person that perhaps is reluctant to engage within the strategy. We provide that initial support. So I'll talk about some outreach numbers just quickly in a minute, but it also builds on the trust. It is reducing the stigma, and we do increase the engagement of those underserved and those ethnic minority groups. You know, we have had pockets when we've done hits, for example, where an ethnic minority group is not wanting to engage, but we go back and do that one-to-one work, and we slowly sort of break the barriers down and start to engage that minority group. But just to finish off with some real headlines for us to talk about. So as I said, we've been in a pandemic, so these are probably not a true reflection of 4 years worth of data, but certainly a 6 month worth of data, because we have been unable to do face-to-face contact with prisons. I'm sure everyone's well aware. But you know, we have around 60, 70 prisoners trained as Hep C peers, you know, within the estate, which is amazing. We've delivered over 2,500 awareness sessions to try and reduce that stigma and raise that awareness within the staff and within the prisoner cohort. And we've been able to engage with probably just under a third, or just over a third of the prison population, so 26,850 people we've engaged with in this last year. And that is either one-to-one intervention, you know, proper one-to-one, sat down, really speak to people, some brief interventions, attended liver clinics, supporting people through treatment, going back to try and re-engage with people that perhaps disengaged for whatever reason. And this year we're going to try and break that data down to even fine tune it, so you can get a clearer picture of actually what the outreach is we're actually achieving and where we need to prioritize. But importantly, we've also, in that process, we've made a further 12,500 referrals to healthcare for repeat tests as well. So it's a great opportunity for us to try and build that strategy and look towards how we're going to maintain this as we go forward, and as we come to the end of the strategies, how we're going to leave our legacy that everyone can carry on without our initial support. So we are looking at ways there, and I think it came up in earlier on meeting as well, and it's come up today about how the peers as well can do wider health promotional work as well, and we're certainly doing that at the moment as well. So that will roll out as the strategy progresses over the next few years. With that, I'll pass back to Georgia.
Thank you, Sean. And just to note as well, I think people know that the Hep C Trust peers are really intrinsic to the HIT testing, but they also are to the reception testing as well. And there are some examples of peers getting really involved in some of the wider work of the prison healthcare teams as well. So it's not just within HITs. So next slide, please. I think for most people who I speak to about reception testing, they know how much I sort of go on about how important it is. And we do want to ensure that people don't forget in the shadow of the HITs how important the reception testing is, not just for micro-elimination, but to close that front door into the prison. So we do always try to remind everybody how important it is to keep that momentum up, keep testing upon reception. But we do also recognise that it's extremely challenging, especially in those prisons that have really busy receptions, high turnovers to keep up with the churn. And some prisons are getting hundreds of receptions a month, so it is a significant ask on those. But I do want to highlight that there's been a huge improvement in the reception testing in the past few years. So nationally, it was less than 11% of all receptions were tested for Hep C or within 2 weeks in 2016-17, and now that's risen to over 52%. There was a slight dip during COVID, but it seems to be on the increase again. There's also plenty of prisons that achieve between 90 and 100% of all receptions tested nationally, which is an outstanding achievement. And I also want to note that we're very aware that there are recording issues in terms of the data in the prison system, which we have our prison data group to try and rectify some of those issues. So the success of this has been down to lots of factors, including the commitment and determination of the prison healthcare teams to consistently offer and provide blood-borne virus testing to all. This isn't just Hep C testing, it also includes Hep B and HIV as well. And often people are kind of triple tested. So it's not just even about Hep C elimination, it's about the other blood-borne viruses as well. So another success is that we've got a programme of working with the prisons to sort of determine the most appropriate testing mechanism for those, which has more recently included some of the Cepheid machines. We also have some work to do, though, to keep pushing these figures higher. So the national average is still below that optimal performance standard, so there is still some kind of room for improvement. Some of the things that we're trying to do to support teams include ensuring that we've got sort of a strong communication and engagement with the prisons and the healthcare teams. So we work really closely with Her Majesty's Prison and Probation Service, HMPPS, to work with communications to prison colleagues so that they understand their importance and centrality of helping us reach elimination. We've also created things like graphics and training videos that we send to prison healthcare providers on how to best perform things like the opt-out tests. And we've also had a partnership between the NHS, the Hep C Trust and Prison Radio to communicate to prisoners and inform them of their options when it comes to testing. So this is a really interesting one because it provided us with an avenue to tell them that if they missed out on bloodborne virus screening at reception or they declined it, that wasn't their final chance to have one, and they can go and speak to prison healthcare or a peer if they think that they might have been at risk and that they'd like to have a test. So our partnerships with numerous organisations also help make this happen. So as Sean's kind of alluded to, it's not just the prison teams, but also the UK HSA, prison healthcare, the prison officers and the governors, probation teams, and our pharmaceutical providers as well. We also have projects that assist us to promote reception testing, particularly both before and after prisons have undertaken hits. So not just reception testing sort of generally, but when prisons are about to have a hit or just after, we kind of put additional work in to ensure that the reception outreach process is kind of key to the hits as well. So next and final slide, please. So it's these sorts of partnerships and initiatives that have assisted us in getting us to where we currently are. So we have already had some very notable achievements, including over 2,000 prisoners tested, treated in the past 2 years. This couldn't have been done without all those prison and community peers who have worked tirelessly to raise awareness, train staff, recruit more peers, and support individuals in prison get tested and stay on their treatment. And as kind of Sean's already alluded to, even with COVID and many restrictions going into prisons, we manage many hits each year, including 19 in 21-22. And that doesn't even include some of the smaller targeted hits that we have on individual wings or when mop-up exercises are required. This will, of course, continue into 22-23 and probably beyond that as well. We're still trying to target some of the busy remand populations. So another thing to note is that we have the micro-elimination targets. So we awarded more than 20 prisons micro-elimination status for 2021's World Hepatitis Day last July. And we're hoping that there's going to be many more declared micro-elimination at this World Hepatitis Day. So I also know that this presentation is around prisons, but we can't forget some of the settings that are connected to the prisons in and around the criminal justice system. So I also want to mention that we have some achievements working outside of prisons. This is really important just to note because not all individuals who might be at increased risk will necessarily ever see the inside of a prison or might not have been in prison for a long period of time, and we don't want to miss those or forget about them. So many people in and around the justice system might not have had a reception test for quite a while or not have been involved in a hit. So we have similar programmes in probation, approved premises, police custody and immigration removal centres as well to ensure no one's left behind. And just to kind of reiterate Graham's final point, kind of watch this space, we will make it happen. There's definitely a programme of increasing the testing in and treatment access in prisons, but we're getting there.
That's fantastic, Georgia and Sean. Thank you so much. Massive information, some incredible achievements there. We are running slightly behind, so I'm going to move straight on to Deanne Birch, who is the lead for Hep C Later, and she's going to be presenting on us the hepatitis C data in drug services. Deanne, over to you.
Thank you very much, Rachel. Bear with me just a moment while I try and actually share the presentation. Bear with me. I can't seem to share. Has Elliot got a backup he can share on my behalf?
Yeah, don't worry, I've put your slides in there, so I'll just find those.
Great, thank you, Elliot. Fantastic. Hi, I'm Deanne. I'm in the privileged position of newly becoming the lead for Hep C later. Could we just go to the next slide, please, Elliot? It's probably worth explaining who Hep C later are to understand the data that I'm going to talk about, or some of the challenges with the data. So we're an innovative collaboration between the NHS services that we work with and Gilead as well. And we do intensive work in drug and alcohol services based in the community across the country. So currently, as that stands, there's about 15 NHS trusts that we work with. There are multiple services within each trust as well, so that, you know, service-wise, you know, it's near on 60. We're a small team, but they're a team of absolutely brilliant specialists who have been working in the field for many, many years. And we have, you know, Candy, our project manager, you know, Louise Hansford, most of you will know, been working in the Hep C field for a very long time. She's one of our great coordinators. We've got Rob, who does our data, Eddie on marketing, and we've also got new recruits coming in, and we work closely with Matt Milner from Gilead as well. Our main objective essentially within the drug and alcohol services that we work with is to, you know, reduce the barriers to testing and treatment, improve, you know, the prevention work that we do, and also integrate the testing as sort of core work within the services, and we link up key stakeholders to kind of work through some of those issues. We use data to drive our work, you know, significantly. It's a significant part of what we do, all to reach micro-elimination. Next slide, please, Elliot. So I've obviously mentioned micro-elimination. It's been mentioned before. So it's worth putting a slide in, I think, just to kind of give a nod to what that is. Down the right, you'll see the micro-elimination criteria that's currently in draft for community drug and alcohol services. So what this is essentially is Gilead have led a drug treatment service provider forum, which is an incredible collaboration between loads of different services across the sector. So you've got the Hep C later team representing the NHS Addiction Providers Alliance, those 15 NHS trusts that I was talking about. You've got the Hep C Trust, you've got representation from NHS England, you've also got a representation from the third sector as well, so CGL, Turning Point, Humankind, and so on. What we've aimed to do with this is pull together an agreed criteria for micro-elimination. Now, that is probably, as you can appreciate, quite a tricky thing to do. Now, if you think of those NHS trusts that we work with, those 15, the majority of them are using different clinical systems, but even where they share the same system, they might have a different version of it. So pulling data out of those systems can be really, really tricky. So what we've relied on is the fact that we can use the National Drug Treatment Monitoring Service data, because it's something that we all have in common, to try and pull out, you know, this data so we can say when we've actually achieved micro-elimination. Obviously, as you can see with the criteria, you know, offering a test, you know, is a fairly easy win. And what I would say across the drug services that we work with is that, you know, the majority have reached that target. With target 2, so 100% of those who have currently or, you know, previously injected have a test date. Again, many are close, and, you know, some are even closer. I think where it gets tricky for drug services is criteria 3 and criteria 4. So where you've got that sort of need to sustain the testing over the period of a year, especially for those people that are at risk, and also, you know, getting treatment to people as well. I think a lot of drug services are finding at the moment that the more people they treat, then, you know, they've got people that are not treated, but they have really complex needs. So there's a requirement really for us to kind of shift the way that we do things to try and get people into treatment. But they're getting very, very close. Could you press the next button, please, Elliot? So yeah, just the caveat of, you know, this is still being agreed across the sector. And the next button again, please. Fantastic. So I thought I'd talk a little bit more about some of those challenges that we see, because there are multiple challenges around the data. So we've got the challenges itself from the National Drug Treatment Monitoring Service data, the NDTMS data that we all input into. It, on one hand, it's great because it's the common data, piece of data that we can get across all of the different drug services, regardless of what systems they're using. But it has complications in the fact that it doesn't capture everything that we would like it to capture. So it doesn't capture, for example, treatment commencement. And obviously, as you probably guessed, number 4 on the microelimination criteria was around treatment commencement. So we have to kind of think quite, creatively, I suppose, about how we get that. It doesn't capture when someone's got post-treatment bloods, and it doesn't capture all service users. It's only those instructed treatment. So, it won't capture everything for us, but it goes, a good way towards, us seeing, the level of work that we're doing. Obviously, as well, with NDTMS data, there's different data sets change. So essentially what that means is that, different bits of, data is collected, over a period of years. Things are added in, some things are taken away. And with that, guidelines change. So one of the challenges for the service then is around consistent recording, making sure that, all the staff in those drug services actually, have understood those changes and have incorporated that into the work that they're doing. Obviously, I've mentioned about the different clinical systems. It is a challenge, especially when we start to do data integrity work as well, when we really want to sort of, dive into that data. We have to, learn all of these new systems, and there are nuances to every single one of them. There's also challenges with pulling out reports on a service level. So some systems that's just a bit tricky, but also, not every service is blessed with a data lead that can do that for them. So there's a lot of work to be done in terms of, going back and forth with that data and making sure we're really reaching everybody that we can. There's also challenges within the partnerships that we have, because obviously we have to work across different partnerships with the ODNs, hepatology teams. And we need to make sure that we've got data sharing agreements between organisations. So sometimes that can be a bit of a challenge to sort of get that moving. But many services have done that, and now they're feeling the benefit of sort of that sharing of information back and forth, so they can make sure they're updated when people are treated, or they're aware, of when someone's, moved to a different area, for example. So next slide, please, Elliot. But it's not all bad news. So, despite the challenges, there's lots of streams of work that come out of that, which are, really, really positive. There's work that we can do to kind of understand the gaps better in terms of data. One of the things that HCV Data does is pull the reports together for each of the trusts that we work with to, look against the, microelimination criteria, but also to look at data anomalies. And then we can quickly go rectify those. We can try and understand through that data as well what the ask is of each recovery worker, because obviously, as you can appreciate in drug and alcohol services, there's a lot thrown at them. They've got, a lot to do, and this is another thing that they have to do. So we need to make sure that they understand exactly what it is they need to do in terms of testing. So what actually are we asking of them? There's things like the UK HSA unlinked anonymous monitoring survey as well. So again, that can give us really good information about prevalence, but also drug injecting risk behaviours associated with that on a sort of localized level, which I think is really useful for teams, especially when they're looking at the provision of services. There's also good old service user feedback as well. I think that's particularly important at the moment when it comes to needle and syringe provision. But there's lots of examples of all the different strategic pieces of data work that we're doing. So there's that cross-organisation sort of data cleansing, the sort of back and forth, making sure that we know who we've got. There's things that we can put in place like honorary contracts as well that can hopefully resolve some of those issues with those systems that services are experiencing. There's things like data dives as well to look at those nuances that we keep finding in the data, and sharing what we've learned across the sector. And hopefully something we'll be doing very soon, I think it's next week, is a data forum, and hopefully that will open up lots of organisations talking to each other and helping each other to sort of problem solve some of these issues. There's lots of continual data integrity work, and some services have even made alterations to their systems themselves so they can capture the things that the NDTMS data doesn't tell them. So capturing treatment starts, for example. So there's lots of innovative work going on around the data. And also looking at different innovations. I think, there's a service who pulled together a spreadsheet that automatically updates, tells you when things are going to go out of date, and that can be given to each key worker. So you see some great examples of work across the sector. Next slide, please, Elliot. So the UK HSA report, I won't spend too long on this because I'm conscious of the time, but essentially, Hep C infection falling, great, treatments increased, wonderful, and also mortality reduced. But let's not forget, I think, about the prevention side of things. I think COVID has had a great impact on the drug and alcohol services in the community and the prevention work that we can do, that good old harm reduction. So I think there's quite a few things for the drug and alcohol services to focus on in the future. Needle syringe provision, the messaging that goes out to service users is one of those things. But I think, utilising the peers, in keeping the testing, continuously going, keeping the momentum is really important, not only to reach the micro-elimination criteria, but just to, just as good practice moving forward. I think we need to look more at the sort of minimising the pathway length to treatment. I think there's more work that can be done there. And like I said, because I think, we have treated those people that are, very happy to have treatment. I think there's something in how we creatively look at how we engage people into treatment, across the sector. I think people have got, a lot of work on their hands, I think, to manage all of those complex needs. There needs to be, a bit of an increased focus on reducing backlogs as well, because the more we test, the more people we find, and therefore, we've got lots of people to treat. Do we have everything set up to be able to do that? And also the continual data work. We need to evidence our progress, but we need to, assure ourselves that we've done everything we can. Next slide, please, Elliot. So some of the positives here is at the unprecedented level of resource and learning and data sharing that's been happening across the sector. It's been actually quite a privilege to see. There's that national collaboration, with peers, with ODNs. It's just wonderful. I think as well, we've identified and treated, a lot of people. That mortality is reduced, quality of life is improved for people as well, and that's incredibly important. If you can press the next button, please, Elliot. So some of those future challenges, I think I've probably spoken quite a lot about future challenges because there are many, is keeping pace with those, infections and reinfections as well. But also something in how we build resilience into the services as the resource ends. We're, for example, a 2-year project. So eventually, our level of resource and input will go. So we want to leave community drug services in, a really good position to continue with the testing and treatment work. One of the challenges, I think, is capturing treatment commencement, but I know there's a lot of work going into that at the moment, so I don't think it's going to be a massive challenge moving forward. I think maintaining elimination status is potentially something people need to look at. We can reach elimination, but we've also got to maintain it, we've got to stay there. And also the services themselves are actually under a huge amount of pressure. With the drug strategy bringing in more funding and more roles is fantastic. There's still a lot of work that they need to do. We need to make sure that testing remains a focus within that. Next button, please, Elliot. But there are loads of opportunities. So I've spoken about those challenges, but the opportunities are that we've had the chance to link with other streams of work that are linked to this work in some way. So naloxone and drug-related death work, for example. Lots of different organisations and interventions that have proved really useful and are sort of beneficial for the Hep C field. The approach of working this collaborative way is really transferable for many other things in drug services, and I hope it continues. Hopefully we'll continue to build on a really highly skilled workforce as well, because this speaks to really good quality of care, the amount of effort and skill that you know, people have shown, you know, throughout the last couple of years, and you know, will continue to do moving forward is wonderful. And ultimately, I think, you know, giving people a better chance to, you know, fulfill the recovery, to go into recovery, because they have been treated, and this is one less thing to worry about, is also great in terms of opportunities for people, and, you know, at the core of everything that we do. Next slide, please. So that is me. So I'll say thank you. And I think it's questions afterwards. Thank you.
Thank you so much, Deanne. That was really good, and so much information, and particularly on that last slide, you know, the kind of the opportunities moving forward, and to be mentioning prevention, maintenance, needle and syringe provision, and we've heard it already today, you know, reinfections. I'm going to move on now just to our last speaker, not just to, who also needs no introduction, Stuart Smith, who's the Director of Community Services for the Hepatitis C Trust. And Stuart's going to talk to us today about community outreach data. So over to you, Stuart. Stuart, you're on mute.
Yeah, Stuart, you're muted.
Oh. We can't hear you, no, sorry.
No. Oh.
That's strange, we could hear you earlier. So whilst just while Stuart's sorting out his volume and his speaker, I just wanted to remind everybody, if you've got questions, I've managed to pick up a few as we've gone along, but if you've got questions, then please don't forget to put them on into the chat box. I picked up a few. We will have a little bit of time. I'm hoping Stuart's volume will get back on, and then we'll have a little bit of time after Stuart speaks. I think there's been so much information, really interesting to hear the different perspectives from UKHSA, then Graham's perspective, which was fascinating, but also along. Stuart, are you there? No, it's gone. So fascinating that, not fascinating, but really interesting, and in line also, you know, the fact that we're having these we're going to have these extensive pieces of research, 100,000 people tested, 10,000 in the drug services, really important pieces of work to provide that additional data that we need. Okay. Oh, there we go.
Oh, great.
So you don't have to listen to me anymore. So I now hand you over to Stuart.
Thank you. Thank you. So thank you to HCV Action. Thank you to Rachel for hosting. I'll try and catch up with myself a little bit. Sorry about that. So I would just firstly say that I've been feeling quite emotional throughout this webinar. There's an awful lot being done, and the data, I think, shows that. I think everyone is able to poke holes or challenge, and anyone who knows the Hepatitis C Trust and our history, you know, we will always challenge, but we also acknowledge the incredible work by not just our peers, nurses, frontline workers, partners, all the partners in what we're trying to achieve for a common cause. So I've been in awe of that this morning. Hopefully this will be a bit softer than on the data front. If we can go to the first slide, that'd be great. What I thought I would do from the Hep C Trust end of data is try and just explain how we use data and sometimes why we're using it and in what areas. It's important to note that we're probably the last to the table data wise. So we aren't, you know, we're relatively new in delivering services. So our data systems have had to adapt. The pro to that, I suppose, is that we can design systems that are very current in the modern day of treatment. But I think, so the purpose of today is to show everyone on the call how we collect data, because we are very open to working with UK HSA, NHS England. I think it's apparent that we're working with a lot of people now, and if we can improve our data collection and it can help us to measure our progress towards elimination, then we're very open to comment on that. So I've divided our data, as I've always done, into awareness and testing data, which was our bread and butter before the new drugs. And in fact, when it comes to Monica mentioning how do we measure people knowing that they have an infection when they come to get their result, and how do we generate more awareness of how people can keep themselves safe, that's something that we've always done at the Trust, because prior to the new treatment, when it was interferon, we were very impartial about whether people took treatment or not, but we wanted people to understand what Hep C was, understand if they did have it by getting a test. So I'm going to talk about our awareness and testing data, which sits on Google Docs because it is non-person identifiable. And really it measures our outreach activity and where we're going. And it can, with regards to the testing, ensure that we are covering all corners of ODNs. I'm going to then talk briefly about our patient management system, which we use once we find positives. It's a much more secure system. It was designed not to give data, essentially. It was designed from the front up to support patients through the pathway and to support our peer workers to give them the best support that they can have. So I'll talk about how we use that system. And then lastly, I'll talk about our volunteer development systems, which again has become a really important part of our work with so many volunteers now. How do we look at risk with regards to volunteers, ensuring that we're DBS checked everyone, recording their activity, and also progressing them, giving them skills, giving them accreditation. So next slide, please, and I will get into it. So when we first started our peer programs, we would give people a Google Doc, and the first thing we would do to a peer support lead in Newcastle is we'd say, right, we need you to map every single area, where they're handing out food, where's homeless services, where are drug services, where are clinics. So we do a big map of the ODN to try and inform really the introductions, the partnerships that we need to build so that we can go and do testing events. So next slide, please. So in our awareness and testing data, we essentially, we record who's done an activity, where they did it, how many people attended. We have little surveys that we do to make sure that the people who are having awareness interventions understand what we're telling them. And we also record the number of staff who are often present. There will often be 1 or 2 staff and maybe 10 service users present at our awareness events. The testing, a lot more complicated. So essentially we were never commissioned to test in the first place. That has come online and developed significantly, even to the kind of tests we do. But it's a lot more tricky for us to monitor. We are not in control of most of the testing that gets done with our support. So obviously if we use a rapid antibody test, then we know how many people come up positive on that test that day. But we've moved to, sometimes we will actually do wet blood, some of our peers now, capillary testing, DBST, where the contract is with another service and we aren't going to get given those results back, and we would have to request them later to find out what actually happened on the day. And then obviously now the Cefiad machines that are happening, they're sort of, I think, every sort of month we're having a new Cefiad machine delivered in so that peers can actually run those machines themselves. So we've had to adapt our data collection around an ever-changing field, and a field that often we don't have control over. I've thrown in some figures for the last financial year. So we did actually reach 32,000 people. 10,000 were staff that we engaged in conversations about hepatitis C, and just under 20,000 people got tested within our community outreach program. Next slide, please. So this is a sort of look at the Google Sheets from the back end. The top one on the left there, just basically where we've been, what sort of intervention would you do, how many people attended, how many staff, and how many people requested a test and then got tested as a result. The one below that is our attempt to try and record the results. And as you can see, it's complicated. We need to review it. We need to work with partners to see how we can better monitor and get a useful picture. I'm certainly of the principle that if we're not getting something really solid and useful out of, you know, these huge spreadsheets, then we shouldn't be asking our teams, who are all very busy, to be recording it in the first place. But it's evolving. So out of the top sheet, we're able to ascertain that 2,202 staff in frontline services attended our HAP program, which is our hepatitis awareness training program, delivered by our peers. I think it's over about an hour and a half. We're able, the pie chart, you can see, often the devil's in the detail. This requires a bit of manual effort from our end at the moment to look into things. But for instance, we know we've got a Cefiad in Kent, and we can look at how much testing is done by Cefiad and how much is done still with rapid antibody tests and how much is DBST. So we can get a picture of the type of testing that's being done. Again, it's the results and actually putting them back to a person that is tricky. What we do know is if someone comes positive, they certainly end up on the next system that I'm going to talk to you about next. So we don't lose people, but recording all of those results on the day is always difficult. Again, I can look at Wessex data in detail and see that over that year, 710 rapid tests, so our rapid tests were actually done, and 142 of them were antibody positive, so about 20%. We can't wait to have a rapid RNA test because obviously we're in a new era now, and we've seen it on the other slides where the antibody tests aren't always telling us what we really need to know now. Next slide, please. So now we're into our patient management tool that we use, which we are very pleased about. This basically was designed in how can we make sure that people that we're working with get the best support and navigation through the pathway. I myself have been subject to another clinical pathway recently, and I've been to 3 different hospitals, all of which I had to open a letter and find out where I was going next. And I didn't really know why I was going there until I finally met a clinician months later. So it really became apparent to me how valuable this pathway navigation is to our patients. And this tool has been designed primarily to support patients, not to get a data picture out of it. However, what's been happening is we've now got over 9,000 patients, all of whom are Hep C positive. I think 99% are RNA positive who are on this tool. So it's obvious now that we've got some data. It's about how we can make it meaningful. And that is why I wanted to show more professional people who are much more, expert in data, how we use our systems today. So essentially down the left-hand column is very static information. They're fields that we can choose. So we've developed this system. So it can be all about Hep C, which we're very fortunate about. And then in the middle, there's a timeline of the history with the patient. And essentially what you do is you log what you've done that day, and then you set a task as what you're doing next. And it's very quick. So someone can just say, look, I've met so-and-so at probation. He's got his phone back, explain his meds are ready, and he will be in touch on Friday to arrange. what that does, and Izzy is one of our workers, by the way, and I have grayed out the patient name. But what that does is it allows Izzy, who's now managing maybe 100 patients, when he next meets with this patient, there's a real personal element because he remembers exactly what, you know, for example, he's got his phone back now. Izzy can now say, how's your new phone? It's as simple as that, and it makes it feel very personal. So it's been designed to be a personal support tool for our peers to use to support someone to treatment. Next slide, please. And I just wanted to show, you know, the beauty of this system that we use. It's got a fantastic app. All of our workers are out and about every day. They can very quickly find a patient, call a patient. It logs that we've called them. They can quickly talk about what happened in the call, and they can go in and enter and update data, whether they've got an SVR now or whether they're due for their next, you know, meds collection. So it exists across at home on the desktop, if you like, on your laptop, but then it integrates really well with the mobile. And one of my favorite parts of the app is that when you set a task, which I encourage every worker to do, so don't forget to call Sarah in 2 weeks about her results. In the morning, our workers get a built-in notification to their phone saying, don't forget to call Sarah about her results today. So it allows them to give a really personal treatment to those they're supporting. Next slide, please. So data from this system, like I said, we've got over 9,000 patients now on this system. If I just follow you through the columns by year, you can see that we've increased activity year on year throughout COVID, thanks to the amazing nurses, again, frontline workers, all of the teams involved who've done fantastic work through that dreadful period. But you can see in 2019, we found 1,500 patients, 1,300 of them were RNA positive, and 1,100 got treated as a result of being supported directly. And I've put in there 83%, so that's 83% of the people that we find and support have received treatment. Into the next year, again, our numbers increased significantly, 2,500 almost, 2,100 confirmed RNA positive, and 71% of those successfully got treatment. And then in the year we've just had, again, a huge increase, 3,700 patients found, 3,200 PCR positive, and 78% of those patients were treated. Next slide, please. Okay, so a deeper look. So we've added fields as we've gone to the patient management tool. I think in April 21 we added are they currently injecting? That field I looked. I mean, these slides are going to get worse over the next 2 minutes, by the way, because as it got to close to 10:30, me handing them in. But so this morning I looked, we've got 600 people that we know out of 4,090 found in 2021 that we have something in this field. And as you can see, there's a split between current injectors and previous injectors, which actually ties in with some of the data we saw earlier. And then since this April just gone, so very new data set for us. So far we've found 343 patients since April, which is incredible as well. But we know that 217 of those are in a drug service. So this now we need to use this to inform our work. We need to go beyond the services, as I've written there. We are going to be not pulling out of drug services, but certainly detaching with love is a phrase that I've heard recently. We would want to continue all that really important activity, carry on offering the training. Certainly those clients that are very much more difficult to engage them into treatment, but move to a model where drug services are already doing a great job of looking after their own clients with regards to Hep C, and that they need to for sustainability. So this data will help inform that. We've got other data sets in there now, such as how many people are we working with who are rough sleeping, not in touch with services, or in temporary accommodation. So more will be revealed on that new data set that we've added. Next slide, please. So, and lastly, on our volunteer development, which has become really crucial, we've now got a volunteer manager who's doing a fantastic job of monitoring how many volunteers we've got across the country. And this is really important data for us to also manage as well. We need to understand where our peers are, what they're doing, what sort of training they're getting. Are they ready to do one-to-one support, or do they need some more training to be able to do that? So we've got a fantastic team looking after that now, and they're also using Google Docs because it's largely, I think, non-patient identifiable data. Next slide, please. And this is obviously some names, so please put your blinkers on there. Just to say that these are back-end systems that we use. We've got applications to process, risk assessments, DBS. Again, we weren't a volunteer organisation 4 or 5 years ago, so we've had to develop these systems. We've now got 120 active volunteers, which works out approximately 4 per network. And last year we did 13 face-to-face 3-day training events across the UK, with 118 of those peers getting trained to be out there and delivering our work. Next slide, please. And this is the final slide, so I will just leave you with that. These are the top line numbers that we get from our systems as they are at the moment. But again, the devil is in the detail. And as we are moving towards elimination, I think what we would like to do in the community program is get a real handle on, are we covering all the corners of the ODN? And are they, you know, what sort of testing are we seeing? What sort of positivity are we seeing? And working with partners like UKHSA, NHS England, and drug services to really understand what sort of picture is that data starting to deliver us. So that's it from me. Thank you.
Thank you, Stuart. That was it was a great presentation, and thank you for all the detail. I'm really conscious that we are 1 minute from 12 o'clock. I've just found out that we can extend slightly if other people are available to stay, just to answer a few questions. I'm not sure about the panelists. Can we go back to the main screen? There we go. Okay. So is everyone okay just to stay for a slightly little bit longer? I think we lost Graham. Is Graham here? Perfect. Perfect. So there's just just thought if I pulled out some of the questions out of the box as they'd come up. So is Graham here? Graham, you are. There's a question for you.
I hope so.
Sorry, I couldn't see you. So the question for you is, can you tell us a bit more about the uptick in hepatitis C related HCC? Are most of these occurring in RNA positives or in RNA negative treated? Different strategies would apply to reduce the incidence of HCC.
It's a great question. Something that's really vexing us. The numbers are quite small at the moment, but clearly the tick is in the wrong direction. What we're hearing at the moment is the majority are in RNA negative, so cleared hepatitis C, but we do need some more work, we do need some more data, and we're pushing that. Monica may have other insights into that. Monica, it's your data, but I don't think we've yet got as deep into that as we need to. But I think all the centres are seeing a surge, I don't say a surge, a number of previously treated patients presenting late with liver cancers. We're picking a lot of them up, fortunately, with our screening programs, but really important everyone stays on an ultrasound surveillance program. And important we factor it in when we're selling the benefits of the program. We are going to see more cancers, but it is a reflection on people living longer.
Can I just ask then, so I know something that's come up through the infected blood inquiry for people that have had hepatitis C, then completed the treatment, is the access to surveillance. So, you know, for someone like myself, for example, you know, I cleared the virus in 2007. I've never been asked to go back for a surveillance, another screen, you know. So how do, if we are now seeing this, you know, and it's a consequence, the liver, the damage to the liver, then how do we ensure then that people are accessing surveillance regularly?
The sad truth, Rachel, is that the risk of cancer is only high enough in people with cirrhosis and other risk factors to justify surveillance. That means there will be a few people who will not be scanned. We've all got horror stories. I recall a lady presenting in pregnancy with backache who had disseminated liver cancer, despite the fact that she had a genotype 1 treated with mild disease 5 years before. So we all see those horror stories that break our hearts. We just don't have resource to screen every single person with hepatitis C every 6 months. And a decision on cost effectiveness has been made internationally, I have to say. Most people agree the risk has to be more than 2% per year to justify a surveillance scan. And that's where we're making the cutoff at the moment. I think we're all anxious about comorbidities, people who are continuing to drink, people with diabetes, obesity. If you've got F3 fibrosis and diabetes, what's your cancer risk? A lot of us tend to scan those people, but it's quite an arduous thing, both for the patient and the health service, to do a 6 monthly scan for 10, 15 years. That's a lot of effort from a lot of people, including the patient. So we haven't quite got this right, but if anyone has cirrhosis, they must be on a surveillance scanning program. If they have comorbidities, I think they should be. Otherwise, I think the sad truth is we are going to lose a few, but we just don't have the resource to scan everyone who has mild disease and has a low rate of cancer. But tragically, it's not a nil risk. Yeah,
no, I thought very much that was going to be the case. Monica, you got your hand up there.
I was just going to say, to add to that, we've now, from the infected blood cohort, so in the registry, we've now got longer term data as well. So we'll be looking at the survival analysis data for the next 20 years shortly. So we'll have more up-to-date data on the natural history as well.
Okay, so there's another question that's come for Graham there. Is there data that identifies any particular genotype in those presenting with HCC?
Numbers from the UK are probably too small to comment, but globally we know genotype 3 is a bad risk factor. It's one of the reasons I'm very keen that people get genotype. I think if you are in a hurry to get people on treatment, for good reason very often, starting therapy with a pan-genotypic and then doing a genotype later is still a very valuable addition, because genotype 3 is a bit of a Rottweiler when it comes to liver cancer, I'm afraid.
Yeah. I just wanted to bring in here, there was a comment, I think it came from Eamon, who's had to leave, and he just putting, because I think it's really important, he says, I completely agree with Graham, a people not pathogen approach, treat whole needs of a person, not just focus on specific infection. I think as we move forward, this is about data and this is about us reaching the hepatitis C elimination, but part of this, when we're considering the maintenance, is about the whole approach as well. You know, and in fact, well, I mean, not just the maintenance, but it's about the whole approach, whole health approach. There was another question here around, there's some amazing testing. I think this is going to you, Georgia and Sean. So amazing testing work happening in prisons at the moment, but it seems impossible for drug services to get information on someone testing status when they're released back into our services. I don't know, and Deanne as well. I mean, is there something around this? They only get basic information. How can this be improved?
Yeah, it's something that's been flagged quite a lot, Rachel. There's obviously the Hepatitis C Trust Follow Me form that we try and encourage the use of, but there's not really anything that we can kind of implement that has a kind of system lever to ensure that people fill that kind of information in. But we are continuing to do work. It's not just about testing and getting people onto treatment, but it's following them throughout the pathway as well. So it's on the radar.
Perfect. So we've got a little bit, so I've got a couple of questions here for Monica. So methodological differences between NHS England and UK HSA estimates perceptions. What additional data do you feel we need that we don't already have?
So it depends which of the estimates we're talking about, but we are, I think, as we've always said, we are really keen to consider any additional data that is generated, but we'd need to understand the methodology that is used to develop, for those data to be incorporated into the modelling work that we do, but absolutely keen to consider any other data that's generated.
Can I throw that to you, Stuart, as well? What other data do you think we need?
I think we need mapping data, possibly. So are we in all corners of the ODN? So for the community seems to be probably, I mean, I think prisons is relatively straightforward, although I know it's a huge amount of work, but you've got a contained audience there. We're measuring people in structured drug service because that's all we can measure. But it's important to remember that every local authority has almost half the people not in structured drug service who are at risk, often more at risk. So it's how we get that data, and that's why I really wanted to show how we get our data in the community, because we are open certainly to working with partners as to how that can be meaningful data. The UAM survey, obviously very good, but yeah, as you dig in and look through the devil in the detail, it gets difficult. I still don't think we've got a reliable picture in the UK, and I think UK HSA sits one side, NHS England sits another side. We have to be together.
Yeah.
You know, by the end of this, there will be many arguments, I'm sure, but by the end of it, we all need to be holding hands and smiling about the fact that we feel that we've eliminated.
Yeah, perfect. Really well said. So
Rachel, just the other one to add to that, where we know that there is really a huge gap and we'd love to be able to generate data, is around needle and syringe provisions. So we, at the moment, the only data source we have for that is the UAM, and it is self-reported. We've got no idea about the provision of NSP, and prevention's a real threat to achieving elimination.
So that ties in really nicely, because there's a question here for Deanne, actually. So what harm reduction measures do we need to improve infection rates among people who inject drugs? So needle and syringe provision, I mean, what do you think?
Yeah, I think there is something in that, you know, we're very good, I think, at getting feedback and data on those people in drug services who are receiving structured treatment. But again, I'm not sure how good we are at the moment of getting feedback from people that aren't engaging in those services. So I think that's the challenge for every drug and alcohol service out there. I don't think there's an easy way to do that, but you know, hopefully through linking in with, you know, people like the Hep C Trust and our peers, you know, we can start to get a better picture of where there might be gaps, or where, you know, our, you know, needle and syringe provision needs to be improved. So I think there's a lot more work to do in that area.
Okay, and there was one more here for you. What are the drivers behind the 30-point gap between those being offered a test at reception and those taking it up? It says to you. So I mean, I think that with reception, I mean, I wonder if is that to you, or is that to
I think that might be for Georgia.
Yeah, I think that's to you, Georgia.
What was that? Sorry, Rachel.
What are the drivers behind the 30-point gap between those being offered a test at reception and those taking it?
Yeah, so we're not sure. So that's kind of one of the points that I made earlier about ensuring that we make sure that the offer is opt-out. So not asking people, is it okay if we do a test, but saying we are going to be doing a test unless you tell us otherwise. So ensuring that the system know that it's a proper opt-out test, and making sure that we've given them the tools to be able to do that. There might be other reasons as well, you know, if people haven't come across Hep C Trust peers before, and they've been offered tests in different prisons and different settings, and they don't realise that just because you've been tested once doesn't mean that you might not have it at another time. So that's where the peers come in, and they're able to give them that kind of one-to-one support. They're able to engage them in a discussion, and then hopefully then they're tested again later down the line.
Perfect. Thank you. Stuart, you've got your hand up.
Yeah, I mean, I think it's important to acknowledge that we are working in a more and more difficult climate with regards to our elimination program. The road gets more difficult, and on what Georgia just said, testing fatigue. I mean, if I was a patient and I got tested a few weeks ago in a drug service, and now I'm entering reception of a prison, no thanks, I don't want another fingerprint test. So it's really important that we get on top of testing, so that, you know, maybe we can have data sharing. I know, bringing up what Deanne mentioned earlier, I know it's difficult for drug service even to understand why someone's turned up in their drug service being released from prison and being told that they're collecting a methadone script, And sometimes the drug service doesn't even know when they last took their methadone. Was it that morning or the day before?
Yeah.
So there is a data sharing to drug services, but it's minimal. And there are systems that can be, you know, why can't that drug service be told how much methadone that person needs that day? When was their last dose of methadone? And what was their BVV status? But it's a higher level of negotiation than I'm fit for.
Yeah. I think, thank you. Graham's just having to run off. Can I just quickly say, Graham, before you go, and I think probably I'm getting the flag on this side as well. I wanted to say thank you very much to all of you. My gut is that we need to do this again. We need to do this in a year's time. We'll have the next report from UKHSA. We'll have some results from the incredible pieces of research that you were talking about, Graham, the testing of the 100,000, the 10,000. Hopefully at this time next year, we would have some more information on exactly where we're at. We might have some more information around the primary care, etc. So just to say thank you very much for joining us. Please come back this time next year. I hope that, not that we've arranged it yet, but I think it's a good idea. Hopefully the speakers will agree. We have recorded the session, so you can pick up the session online. It will be on the HCV Action website. If you have an opportunity, if you could complete the questionnaire afterwards, that would be really good. But I do hope that it's been a really interesting session for you all. I mean, there have been some incredible presentations. Thank you. The scene has been set, the incredible partnership work that's happening. And I think, as Stuart said, it's incredible where we're at. You know, so let's not forget that, you know, yes, there's a lot of issues, there's a lot of things we need to work away, but my goodness, this is incredible. And it's globally unique, the way in which we're working. So thank you very much. Have a great day, everybody. And I look forward to seeing you this time next year.
Thank you.
Thank you.